Hi people, teacher and classmate, welcome to a new video. My name is Claudio Mar Alvarado Ramos. I will talk about of systemic therapy for metastasic renal cell carcinoma. My social networks are YouTube, Claudio Mar Alvarado, Twitter, Claudio Alvarado, Facebook, Claudio Alvarado, and Instagram, Claudio Alvarado 95. Well, introduction. Systemic therapy is the use of drugs to kill cancer cells. This type of medicine is given by mouth or directly through the bloodstream to reach cancer cells throughout the body. Types of systemic therapies used for kidney cancer include targeted therapy, immunotherapy, and chemotherapy.
I think the way this appears to be most clinically relevant to me is that as you manage large numbers of these patients, there are patients who have very good responses who ultimately are managed with drug holidays. And what we've experienced is as we take patients who have been on more conventional schedules, give them a drug holiday, restart them using the 2-in-1, patients frequently will tell me that this is a much better tolerated schedule. So I think that although the data to support it is not uniformly there, it's been our clinical experience that patients do very well with this particular schedule.
Okay. Applications in medicine. A person may receive one type of systemic therapy at a time or a combination of systemic therapies at the same time. They may also be given as part of treatment plan that may include surgery and or radiation therapy. It is also important to tell your doctor if you are taking any other prescription, over-the-counter or supplement medications. The second video.
The presentation today was an update on the data we have about activity of targeted therapy, namely VEGFR inhibition, after PD-1 or PD-L1 use. So basically, what we do know now from 1 year is that we have changed our standard of care, and in renal cell carcinoma, metastatic disease, we commonly use sunitinib or pazopanib in first line, then nivolumab or cabozantinib are the two options in second line. However, we have very little data about the activity of, for instance, cabozantinib or other VEGFR TKI in the post-nivolumab setting. So this presentation was about the data available in this setting. There is only 2 retrospective data sets who were gathered to analyze the activity of TKI, and mostly axitinib, for instance, in the post-PD-1 setting. What we can tell is that first, these drugs are still active after nivolumab, with median PFS in the range of 6 months. Second, that there is no safety signal. We're fine with using those agents after nivolumab. And thirdly, of course, because this is retrospective data set, we need to confirm that in prospective data. However, we can say that it is safe and that we should offer our patient after nivolumab failure a VEGF inhibition, if possible cabozantinib when not used before, other drugs such as axitinib, sorafenib, and other agents can be used in this setting.
Okay. Pros and cons. Pros, the use of everolimus or affinator and tensorilomus toricel. These drugs slow the growth of kidney cancer. Everolimus affinator and tensorilomus toricel have multiple adverse effects. The third video.
Well, surgery will always be an important part of the management of kidney cancer until we have completely effective systemic therapies, which we don't. So as the systemic therapies grow more effective, then of course surgery becomes less of a role, because ultimately if you have a systemic therapy that can cure metastatic kidney cancer, then surgery really is going to have a very small role. But we're not even close to that. So where all this goes, I think it goes towards risk stratification, a better understanding that some kidney cancers are never destined to metastasize and ought best be watched. With genomic profiling and improved biomarkers, perhaps we'll have a better idea. So the role of surgery is getting refined, just like it is with all malignancies. Organ-sparing surgery is becoming increasingly emphasized. And the complexities of minimally invasive surgery, which we haven't talked about, but laparoscopic or increasingly robotic portion nephrectomy, even for complex cases, is being emphasized.
Okay. I shoot a bleed in Ecuador. Bleeding from fibroids in Ecuador is one of the main cases of gyneco-obstetric care, either because of the anemia that causes long-term bleeding or because of the risk of infertility in young women.
So what we have found is that patients that are either overweight or obese has better outcome in regard of overall survival, progression-free survival, and response rate, meaning the tumor shrinkage. And this finding has been observed in 2 different data sets. We believe an important information that should trigger more analysis in terms of biology to explain this finding. Overweight or obese patient has 24 months overall survival compared to 15 in normal weight or underweight patient, even when we adjust for the known prognosis factor in this setting. And we believe that this is a really substantial difference, and we try to understand what is the underlying biology associated with that finding. So we are now proceeding to the next step, which is investigating the tumors in itself and see why it would be more slowly growing in obese or overweight patients than normal weight patients or underweight patients.
And the conclusion, systemic therapies have shown an important advance in the management of patients with metastatic renal cell carcinoma. In speed, there are no standardized protocols for their use, and it depends on the professional who use them. So there is still a lot to work on studies.
I was lucky and fortunate to participate in the joint meeting of the EAU, the European Association of Urology, and the JAO, the Japanese Urologic Association. It was interesting. It was a mix of European-based uro-oncologists and Japanese uro-oncologists. And we had an interesting discussion what's the best second line in advanced metastatic renal cell carcinoma. And we have those standards in first line, but there's a discussion now with cabozantinib, levantinib, and nivolumab approved in second line treatment of metastatic renal cell carcinoma in some countries. And this talk focused on the value of nivolumab and had an interesting panel discussion. One oncologist had a lady from Barcelona, an easy task. She was pro nivolumab, which is right now guidelines, recommendations, second line RCC treatment. And one gentleman from Japan had the contrapart and voted for axitinib. However, and that's what he pointed out, no head-to-head comparison of nivolumab and axitinib. We just have head-to-head comparison of everolimus and nivolumab, resulting in a longer overall survival benefit for nivolumab as compared to the everolimus, and this led into approval of nivolumab a year ago, at least for the German market. So very interesting discussion here on second-line RCC treatment.
Thank you very much for your attention. Bye.